new normal will take a lot of getting used to. Let's now go into pulmonary vascularity. So now we're looking at pathologies that relates to the pulmonary vessels, not just the shape of the heart, because it's also important in identifying cardiovascular diseases. So this is typical features of pulmonary arterial hypertension. So for chamber enlargement, typically the RV is enlarged. So we can see the prominent pulmonary conus. On lateral view, we have retrosternal fullness. Um, there's upliftment of the cardiac apex and rounding. And we have this markedly dilated main pulmonary artery as a clue. You can see that. If you recall, we looked at the previous normal radiographs. You won't see them as large as this. So try to read on what is the normal value and how to measure. So another feature is peripheral hypovascularity, meaning the distal portion of the lungs don't have um, clear clear outlines of your pulmonary vessels. So what happens is there is rapid tapering of the pulmonary vasculature. So from this area wherein it's markedly dilated, suddenly it's narrowed in the periphery. So that's why it will appear as the the lateral aspects of your lung would appear much more lucent. On lateral view, this is how your prominent pulmonary vessels appear. So it's again diluted. If you can recall few slides back, you won't see this fullness in this region in a normal radiograph. So this is because of your dilated pulmonary arteries, and usually they are superimposed, which makes it much more, and it appears much more large and confluent. Then we also have pulmonary venous hypertension or pulmonary congestion. So in this one, you will see that the vessels are prominent and extends towards the periphery. So even on the most lateral portion of the lungs, you can see that the caliper of the vessels did not diminish. It's just more or less the same as the middle part and as well as in the inner. So it's not tapering as usual. I hope you can appreciate that. So those are pulmonary vessels. They're branching continuously towards the periphery. And usually, in the normal lung, we expect that the upper lung zones would have lesser vessels or less prominent vessels because of gravity. However, when there is pulmonary venous hypertension, what happens is there is cephalization or equalization of the vessels. So the caliber of the vessels here would be more or less the same as the ones that you see here. I hope you can appreciate that. Also, the caliber of the vessels here, same in the upper lung fields. So this is pulmonary congestive changes or your venous hypertension, and usually it's accompanied by LV cardiomegaly. So this is a spectrum of congestive heart failure. So as it worsens, that's when we have interstitial edema. So in interstitial edema, again, you have those prominent lung markings extending to the periphery of the same caliber as the ones in the inner lung zones. And here, pointed by the arrow, that's fluid in the minor fissure, seeping into the minor fissure. Part of the features also of congestion. And on the basal aspect of both lateral hemithoraces, we have these linear lines, which you love very much, the curly B lines. So this is how it looks like. So this is in pulmonary edema, interstitial type, yeah, because as discussed previously by Dr. Agana, you can have interstitial or alveolar um, densities, and at this stage, it's still interstitial. So they appear as reticular network-like mesh. No? And again, we have LV cardiomegaly in this case. Now, this is the final stage. When you have frank pulmonary edema or alveolar opacities, and typical, this is your also again your favorite bat wing, butterfly, or angel wing configuration. So you have alveolar densities of with a somewhat symmetrical distribution on both sides. So if it's taken properly and upright, the distribution will be equal. So if the patient is actually on decubitus, you would see some movement of the fluid and one side would be much more dense than the other. But in the commonly taken upright or supine radiograph, as long as it's taken with no rotation, you'd expect that the densities would be equal on both sides. So this is your frank or alveolar pulmonary edema. So this is the stages, different stages that I showed. First is the progressive cephalization. So that's the one wherein you have equalization of the caliber of the upper lung vessels when you compare it to the lower lung vessels. So more or less same size. The next stage, stage two, is when you have interstitial edema and those septal lines, the curly B or curly A lines. So those are your clues that you are in stage two. Then stage three is when you have alveolar. That's the last one I showed. Perihilar distribution, symmetric, and the opacities are alveolar. So you can also see, since it's alveolar, you can also appreciate air bronchograms in these cases. So those are the stages. Now, radiology-wise, in our part, we don't really put in our impression that it's cardiac failure stage one. No, it's not like that. We just mentioned that there is pulmonary congestion, there's interstitial edema, or there's alveolar edema. This is more of the clinical significance of these cases. So what we see is those findings, we just report it as such. So this is another pathology. Now this pathology mimics cardiomegaly, but in most cases, if we really if we are able to look at the echo or the CT scan, the heart is not enlarged, but what is causing the apparent enlargement of the cardiac silhouette is the pericardial fluid. So this is an example of pericardial effusion. So usually the vessels are of normal caliber. So it's not compatible with heart failure, wherein in heart failure, you'd expect those changes, not the progressive cephalization at least. But in this case, the vessels are of normal caliber, but we have a markedly dilated and enlarged cardiac shadow. So we know that the pathology is not um, congestive heart failure. It's fluid collection in the pericardial um, space that's creating the enlarged cardiac silhouette. So this is what you call as the water bottle sign. In this image, we have a superimposed water bottle, just so you can appreciate what it looks like. So this configuration is also seen in cardiomyopathy. So again, as I mentioned from the very start, chest radiography is a screening tool. So we can't give automatic diagnosis that when you see this sign, it's automatically pericardial effusion. We take it as the primary differential, but we cannot rule out other disease entities. So for most of these cases, we have to do to the echo to check if there is really presence of pericardial fluid. Another pathology of the pericardial space is your pneumopericardium, as seen in this case. So normally we won't be able to see the parietal and the visceral aspect of the pericardial sac, but because of free air insinuating along the pericardial space, it creates an outline and it separates the two um, surfaces. And we see this lucency tracking parallel to the left cardiac border. So this is typical of pneumopericardium.